All right, we're live. So this is Night's Watch, and today's film will focus on One Night in Soho. So where does the group want to start?
Interesting scenes.
You're on.
I don't want to talk about the end right away, though.
Yeah, we'll hold off
Okay.
spoilers.
I guess at the beginning's pretty interesting. She's excited because she gets this opportunity, and then we get a glimpse of her seeing her mother in the mirror, I think casually. So immediately had me thinking, oh, what could she possibly have?
Anybody? By the way, before we go down this bit of a clinical rabbit hole, the apparition that might be described by individuals as being seen in a reflective surface such as a mirror actually has a name. Do we know what that perceptual disturbance is? Now, it's a visual hallucination, and you're right. However, if that were choice A on a shelf exam and choice D said this, choice D would actually be the single best answer. It's called the otoscopic illusion or otoscopic illusion. Right? And there's two aspects of this that are kind of interesting, although one of which applies to this movie, perhaps. Number one is who's at risk. Now, I think it's not going to be at all surprising to know that people with primary mood disorder, a primary psychotic disorder, are at the very highest rank of that risk. And our character seems to fit that profile. So now, whether or not the writer-director understood that and wrote that in, who knows? The other part of this is that individuals with this condition tend to be, for lack of a better descriptor, creatively minded. So actors, actresses, artists, which again kind of fits here too. Again, intended or not, I probably would guess no, but a nice academic coincidence. And then, and this part has nothing to do with the movie. The actual apparition itself is actually titled, is labeled as a what? So the actual perceptual disturbance in that reflected surface has a name. It's called a phantom, which is interesting because another character, albeit not in this film, from Andrew Lloyd Webber's Phantom, also is very creative and also happens to see the ghost, the opera ghost, in a mirror. Right? So again, incredible coincidence. There's no real title of phantom here. But otherwise, yes, we have someone with perceptual disturbances in general, a visual hallucination in particular, and perhaps even more specific, seeing a phantom as part of an otoscopic hallucination. Other observations about that opening scene or that beginning of the movie when we begin to understand this character's experience.
I mean, I thought I had a hard time at the beginning just figuring out what decade we were in. It took me, I was really surprised when you get, like, when she gets to London and you realize, wait, this is present time and not actually set in like the 70s or something like that. So off the bat, I thought that she was almost like she was like fixed in a different era.
And I tend to think that's by design.
Yeah,
I think there's like
so.
and because that, I think, hesitation on the viewer's part is then kind of supported throughout the movie as she does seem to go back and forth, and then what is going on. So I wonder if that's some kind of foreshadowing.
I don't know if someone said this already, but I forgot what the exact name is. Maybe it's like bereavement. So maybe I was like, is that some kind of like bereavement towards her mom because she's seen hallucinations of her mom, or is it some kind of like psychosis?
Okay. So do we know when her mom passed away?
When she was 7.
Yeah.
Oh, yeah.
Yeah. So if we heard any signs and symptoms, if this particular character presented for help at or around the time of her mother's death, bereavement, which is normal, right? Bereavement is a normal process, very often interchanged with the clinical term grief. Grief being the feeling, bereavement being the syndrome, right? But so if you want to split hairs, both are considered to be normal, right? When it goes beyond the boundaries of what a clinician would consider normal. We usually refer to as persisting complex bereavement disorder. It's a mouthful, often shortened to complicated bereavement, right? Which may have happened, although even then, we would have expected that to have its onset perhaps within the year of her mother's passing, not a decade plus later. So even that, I think, was something that, if true, and I would suspect that it is, would be something that the clinician would ascertain as part of the past psychiatric history. Because at this point, even that looks like it may have evolved, and also include major depressive disorder, right? So if we were to actually draw up the prequel here, yes, I think we would see a younger character with bereavement. I also think that as part of that prequel, we would see persisting complex bereavement disorder. And I think now in present day, or whatever day it is, maybe a major depressive episode.
But she didn't seem like initially at the beginning, she had like a loss of interest, or I didn't think she at the beginning fit the classification of major depressive order.
Yeah, and that would be a tough call, right? I mean, there's a couple of ways to go about that. Number one is, I think the initial observation, once we bring this idea up, is this some residual of her bereaving? We would then begin to actively look for signs and symptoms that would fit Siggy Caps and see if the writer, director, producer got it right. In the absence of that, I think we would parallel where we would be in clinical practice in real life in-person situations in which a person may not tell us Siggy Caps, and we still operate with a high clinical index of suspicion. Perhaps they're depressed, but they're not expressing it the way the DSM says they should. That happens, right? It happens in children, it happens in elderly, and it happens with people who are neither children nor elderly. So that's something to consider here. The other part of this is, all right, well, because now you took me down this rabbit hole. If you look at that demographic of adults, so I think a child is straightforward. We would never expect a child to come in with Siggy Caps who is depressed, right? It's a behavioral situation. There'll be behavioral outbursts. Similarly, behavioral for elderly, right? However, that middle cohort, us, young adult, older adult, is likely or more likely to conform to the DSM criteria, because the DSM was built through our data. We provided the data that built the DSM. However, even within our cohort, there may be outliers. Give me some examples. And of course, my follow-up question is going to be, is there any evidence in this movie to support this particular character being such an outlier?
Like if you have atypical depression.
So that's possible. Yeah, that's possible. It could be an atypical depression. By the way, you're using big words. What is atypical depression? We should make sure that everybody's on the same page.
Doesn't fit the criteria. of typical depression.
That's fair. That's right.
Yeah, they have like mood reactivity.
Mood reactivity is significant, as is another condition called
Leptin paralysis.
right on cue. That's great. Yeah, leptin paralysis. Right. Also, appetite could be increased. Right. So something to look out for. Right. Sleep can also be increased hypersomnolence. So atypical features. Right. Any evidence here?
I don't know how many hours she slept, but it looks like she was looking forward to sleeping a lot.
Yeah, the sleep is an issue here because it's, just a part of the plot device. So we could delve into that more. Any other clinical situations, any other patient demographics for an adult that might result in their not conforming to the current DSM nosology? The bottom line, and you're going to get the somatoform disorders lecture very soon. The bottom line is that individuals who have difficulty putting words to their feelings, words to their inner experience, are going to be at much higher risk of presenting with depression in a quote unquote atypical way. So again, we take for granted that the individual is able to convey to us verbally what they're feeling, what they're experiencing. When they can't, throw Siggy Caps out the window. Right. In these cohorts, they can actually manifest their catecholamine dysregulation in non-verbal ways. And there are a couple of, I think, prime examples here, which have resulted in independent chapters in the DSM. So give me an example. Eating behavior. Eating and feeding behaviors. Right, so I think from one perspective, none of us would be surprised when we see the high rate of comorbidity between the depressive disorders and the eating disorders. However, a slightly different perspective is to say, catecholamine wise, it's really the same thing. It's with two different phenotypic expressions. One is expressed in the traditional way that you learn as early as your M2. The other one is more of a non-traditional way, a non-verbal way. Perhaps because individuals have a difficult time putting words to their feelings. What is the etiology of the eating and feeding disorders? And therefore tell me why in one's history, one may not be able to develop verbal communication normally. What is a risk factor for developing anorexia nervosa, which is also a factor that will heighten the risk of nonverbal communication being the preferred mode of communication? Early childhood sexual trauma. Early childhood sexual trauma. When your childhood is disrupted like that, there's a tendency to regress back to a time when communication was nonverbal, because we've all there. Regression gets you back there. And what causes regression? Trauma. Right. Regression when you're young, that's where the trauma likely occurs. And then, of course, as an adult, that continued utilization of that maladaptive defense regression. What's another example? And I kind of gave it away already. There's somatic symptoms. So instead of saying, I feel down, I feel anxious, doctor, something, I feel like I'm not right in my body, putting words to feelings when perhaps due to a past history of trauma, individual has an incapacity in doing so, they may actually present with somatic complaints, right? Headaches, unilateral blindness, all those things that the somatic symptom and related disorder chapter captures, right? Again, significant comorbidity between these conditions and depression, one way of looking at it. The other way is to say, neurobiologically, they're similar with different phenotypic expressions. All that said, any evidence as to that perhaps going on in this film?
I'm gonna say no.
No?
No.
What does she discover when she begins to take on the persona of that other character and dyes her hair?
Oh, she discovered her trauma.
What's her trauma?
Sexual
Sexual trauma.
Yeah, so sexual trauma plays a significant role in this plot device. Now, again, I think on the surface you could say, well, that's not her, it's the other person, but isn't that kind of blurred? Yeah, and might this be a way of the author, writer, director conveying to us that this particular main character actually has a history of sexual trauma? And if that's the case, I would not expect her to actually be able to demonstrate SIGI caps, but instead perhaps convey her inner state in a more atypical way, nonverbal way. Something to consider. So that's my long-winded formulation as to why SIGI caps perhaps didn't populate the script. All right. Where else are we going to go with this?
You can also indicate like depersonalization or derealization disorder, where she has to kind of channel a different persona to experience her trauma.
Yep. All right. So there's three main dissociative disorders we should discuss. The first of which you just named, depersonalization, derealization disorder, which is considered to be the mildest of the dissociative disorders. This condition, we'll start out with the oversimplistic definition, one that I want you to make sure you latch onto for your shelf exam. Clinically significant depersonalization and or derealization results in a clinical diagnosis, a single best answer of depersonalization, derealization disorder. I mean, it sounds remarkably simple, but I want to say that out loud because With that, it prompts the next question. What in the world is depersonalization? And then what is derealization? And as soon as we get these relative terms defined, we're good to go, right? So depersonalization. Yeah, right. The individual reports some feelings of disconnect with their own sense of self, their own station, their own body. Yep. And of course, now, very quickly, there's somebody here who's not looking at the eye. One person meets the eye, is thinking, I had an out-of-body experience once. Dr. T, are you calling me mentally ill? No. Right, definitive, no. Once these feelings, experiences are recurring and clinically significant, different answer. Right? Then I think there's a potential for it to be a mental disorder, specifically depersonalization, derealization disorder. The one-time out-of-body experience, no. So everybody catch their breath. You're not mentally ill. Derealization. Like you're in a movie or something. Yeah. Right. So as depersonalization is focused on one's self, one's station, derealization then focuses on the immediate environment. So yeah, one feels as if they're in a movie. Their environment is somehow disconnected in some way. Right? The Truman Show, for a non-horror, non-good movie. Any evidence of either depersonalization or derealization in this film? And give me the scene, just as an example. And, during the movie, to the extent that you identify with the character, I don't know how much you guys get immersed in the film. Identification is that defense mechanism. You could feel it too. Does this movie make you feel disconnected as you're watching it? Because if the answer is yes, you're probably onto something. Any particular scene resonate more than the others? I was primarily focused on the dream sequences, wondering if they were dreams. Was she lucid? Was a lucid dreaming? Was she dissociating? Right. Well, again, that's me. That's just I was reading the room that you were struggling coming up with a particular scene, but again, the dream sequences are obviously a prominent part of the plot device. That said, clinically significant? I think so. Yeah. I think so. All right, so we have as a working diagnosis, depersonalization, derealization disorder. We do. All right, so how do I want to put this in the form of a question? Well, let's go to the next disorder in that chapter, and that's dissociative amnesia, which of course is amnesia that is due to a traumatic event that is beyond that which can be explained by normal forgetfulness, right? So again, if you're sitting at a shelf exam and can't quite think through the answer, you do not have dissociative amnesia, right? Any evidence of amnesia, dissociative amnesia in this movie? Are there details?
I don't think so. I feel like she actually very vividly remembers everything that's happening. It's not like things are happening and then she doesn't realize like where she is. It's more so it seems like she's depersonalizing Dear Living, and like the scene where she tries to stab her former roommate, where she just feels like she's having a different experience.
Mhm.
So that doesn't feel like amnesia.
The only like amnesia thing that I could think of was when she had like the mark on her neck and she couldn't remember where she got it. But then that was also like evident in the scene, so I wasn't really sure. I guess it was like a little bit blurry.
And in clinical practice, that's something that can come up. Like, how did I get injured? Now, again, the over-the-top, oversimplistic example is the individual who has an altered state of consciousness as induced by alcohol, the blackout, who wakes up with an injury and thinks like, I'm blacked out, I have amnesia. I had blacked out. I don't know how I got this. Similar, right? Now, I don't think alcohol played a role. I don't think this was a blackout per se, but that's something to consider. And let's say in investigating this, just for teaching purposes, the answer is yes. That you're uncomfortable to the point where you would like to render the diagnosis of dissociative amnesia. Choice A on your exam would be depersonalization, derealization disorder, semicolon, with dissociative amnesia. Are you going to choose choice A? You guys feel comfortable choosing choice A? The answer is no. Okay, why?
You can have both.
That's exactly right. Because for dissociative amnesia, you would incorporate aspects of depersonalization and or derealization as part of the process.
Right.
You do not diagnose both. The other way of saying this is that when you are rendering a diagnosis of depersonalization, derealization disorder, you have to rule out dissociative amnesia. Now, dissociative amnesia has a qualifier. What is that qualifier?
Can't remember.
True. One more step, quite figuratively and literally. It's a hint.
You can't remember your identity?
Only their trauma.
All these might be the result of trauma. Travel away from one's home or work, and usually the assumption of another identity. What is that called? Fugue, yeah. So dissociative fugue used to be a freestanding illness up until 2013 with the revision to the DSM-5. It no longer is, and instead is a qualifier for dissociative amnesia. So we have dissociative amnesia with fugue and dissociative amnesia without fugue. If the mark on her neck does support at least a working diagnosis, a provisional diagnosis of dissociative amnesia, is it with or without fugue? Yeah, and the smiles on everybody's face.
Without though, because I also don't think that's amnesia. I think she didn't. I
We're
don't-
only assuming for teaching
Yeah,
purposes. No,
But I don't think, I mean, if you're looking at it, like trying to rule in or out amnesia, I don't think it is, because I think she just didn't realize she had a mark, not so much she doesn't remember what happened to get that mark appearing, you know?
Hmm.
That makes sense. I think it's more like, oh, you crash into a table and don't realize that you had a bruise, you got a bruise from it, as opposed to you don't remember crashing to the table in the first place.
but hypothetically, if we
Yeah.
were to say dissociative amnesia,
I agree.
the idea of this might be a fugue state has everything to do with your interpretation of that other character. Is that her identity, and where in time does that exist? It really depends how you want to process this film, right? So, and then finally, the most severe form of dissociative disorder is called dissociative identity disorder, formerly known as multiple personality disorder, now abbreviated DID, in which an individual has a distinct personality state that takes over their conscious awareness. Any evidence here?
Initially, I thought that was what was happening, like, because once she goes down and she kind of looks in the mirror the first time, and then she notices, like, she acts like they're the same person, but like different. So initially I was going with that, but as she kept having the dreams and kept seeing people and having the delusions and hallucinations, I was less inclined to think that was what was going on.
Yeah, she didn't really have like lapses in her memory that were really obvious or cause any impairment to her, which I think is kind of like one of the descriptions of dissociative identity.
And that brings up the next teaching point I was going to make, and that is the hypothetical that we are ruling in DID. Because of those lapses in memory, those gaps in memory that cannot be explained by ordinary forgetfulness, the co-occurring diagnosis of dissociative amnesia. Would you be comfortable in diagnosing both? And why not?
Already included.
Exactly right. So I want you to remember that for the shelf exam. When you diagnose depersonalization, derealization disorder, you must investigate both dissociative amnesia and DID. If anyone rules in, it is that being your single best answer. Similar, if you diagnose dissociative amnesia, whether it's with or without fugue, if there is a distinct personality state that takes over one's conscious awareness, then DID is a single best answer, because it will incorporate both aspects of amnesia, as well as any episodes of depersonalization and derealization. So there's a hierarchy here. Of course, none of the above would be the single best answer when choice D on your shelf provides you a substance that is known to induce these states, because a substance-induced dissociative disorder, like any substance-induced mental disorder, takes precedent. Now you're going to tell me the 5.5 substances that can induce these conditions, and then tell me whether or not you feel any played a role in this movie.
like psychedelics.
Good. So hallucinogens, definitely.
That includes LSD.
That includes LSD.
Does it include ecstasy as well?
Ecstasy is a substituted amphetamine that will be a stimulant. That is also correct.
Okay.
I guess alcohol.
Alcohol. And if alcohol can do it, what other drug can do it? Good. Okay, so that's the 0.5, right? Because that's a given,
Um,
right? It's a 0.5. We're missing two. Did I hear one?
Marijuana.
Mhm. And there's one more. Not opioids.
PCP.
Hallucinogens, yeah. Mhm.
Bath salts would fall under.
Bath salts would be stimulants. Yes, that's synthetic.
Inhaling.
Good, we got it. Inhalants, perfect, right? And I think we brought this up a couple of weeks ago, but I think it's good timing to bring this up again. Who here has seen Paranormal Activity? Okay, one. Okay, do you remember the lead character's name? The male character?
Aren't there a lot of them? I don't remember.
The one male character, but the guy with the video camcorder.
Oh, that was so long ago. I don't
So,
remember.
somebody look it up for us. I want to
The
make
very
sure
first movie?
Yeah, yeah.
Oh, that was a movie.
he doesn't make the second.
Okay.
See that louder?
Micah,
Good.
Yeah.
How do you spell that?
ICAH.
Perfect. There's your acronym. Now, if you watch Paranormal Activity, I think it's very fair to say that this condition, this movie is about dissociative disorder. Okay, no spoilers, but it is. Okay. The lead character of which provides us an acronym to remember the actual medication, drugs that can induce that very state. So methamphetamine and other stimulants, inhalants, cannabis, alcohol, hallucinogens. Just remembering that anything alcohol can induce, the sedative hypnotics can induce as well. There's only one outlier there, and that's anxiety. Alcohol can induce anxiety during its intoxication phase. Benzodiazepines cannot. Any evidence of Micah playing a role in this film?
I think the Halloween party scene. Where she's been drinking and then also drugged. And then starts to see all the men that have been murdered.
Um,
But that's like towards later on. I know the earlier. Like when she's sleeping and going to bed, those are associated with that.
do we know what she's drugged with?
Wait, what?
What is she drugged with?
Well, they only gave her alcohol. That was all we saw.
It was only alcohol, or was she-
No, I think they spiked the drink.
Yeah.
She was definitely spiked.
why was she spiked?
They were trying to mess with her.
So, and what are the common, what are
Like
often referred to as,
GHB.
so GHB would be one. Others, X, yeah, so that's a stimulant. GHB is a sedative, so they're here, all right? And there's actually one more that is also common, that is also here, and that's hallucinogen. Right, ketamine? Right, so yes, there are often referred to as date rape drugs or club drugs. There are three major classes. 3 of the 5 from Micah included, right? So there might be a role here. That the individual who spiked her drunk also induced a dissociative state that becomes the plot device of this movie. So we can't rule these out. And plus there's alcohol too, right? So, I mean, I think, did she smoke pot in this movie? Because they're just missing one, or I guess inhalants too, so. But
Also in the ending scene, I don't know what was in the tea. Oh, yeah. But. I don't know.
so, tea is a magic elixir for what? And why? Yeah. Yeah, and again, from a psychiatry perspective, when you deal with any film that portrays psychosis and or dissociation, the evidence of T is very consistent with hallucinogen-induced psychotic disorder, otherwise dissociative disorder. Those are pretty much interchangeable. And that's because a lot of the hallucinogens are made by brewing leaves or vines with the hallucinogen to make a tea. So it's an allegory or a symbolism, but one that really can't escape us. So. By the way, we refer to hallucinogens, and I heard a couple of other ideas about hallucinogens. I do want to make sure everybody's comfortable with the three subtypes because you already named them. So I want to formally just briefly touch on them. What are the three subtypes of hallucinogens? Maybe an example of each. These are answers you already provided me, so I don't know if that.
PCP.
So PCP is an example of what type of hallucinogen? They're called dissociatives, right? And what's another example of a dissociative hallucinogen?
Ketamine.
Good. Good. Second example, LSD. Psilocybin, another example. And what subtype are they? I think somebody said it before, no? Psychedelics? And then what's the third type? Deliriums. And deliriums, usually anticholinergics, as an example. Good, all right. So again, psychedelics, dissociatives, deliriums, the three subtypes of hallucinogen. All right. What else about this movie we want to touch on?
The paranoia. It's very evident, I think, starting right from when she's in the cab with the driver. Like initially you might think, okay, she's having a normal response because sometimes people can be creepy like that. Like he passed the leg comment, and then he passed the comment about what she was gonna stay in the house with the girl. So she was like, I want to get out. So I'm like, okay, I can understand that reaction, first time in the city. But then she starts to like check to make sure like he's gone, almost making it look like she was being stalked by him when their encounter was only for like a minute. So immediately I could tell she was already paranoid, and then we see that progress as she starts having the dreams as well.
How do we make sense out of that? Again, this were presented as a case in a clinic setting by this character. What's going through your mind as a clinician?
Potentially PTSD. She has the dreams, maybe she's hypervigilant now.
I was going to ask you the proper term. It's hypervigilance. That's right. Quite possibly. Yep. Anything else? I think with the exception of inhalants, and I really have to check inhalants, every other drug you named here, Micah, actually can induce paranoia. So I wonder if it's also, at least in part, the direct physiologic effect of any of these substances that might themselves be causing the dissociation. When dosed, the paranoia is prevalent, meaning when spiked. So, and I'll give you an example. Hallucinogens in microdoses can be used as adjuncts to psychotherapy. So I think, in a standard of care practice, there may be no safer environment than a psychotherapy environment. I mean, rapport is built. You're a patient who has provided informed consent, and hopefully the person providing the psychotherapy is a trusted, ethical clinician, etc. There's no safer environment to actually share your deepest and your deep-rooted fears and thoughts than with your therapist. When assisted with microdoses of hallucinogen, it's taken to the next level. On the other hand, the exact opposite is true when you're spiked. Because of the distortion in time and reality, time and space, it could be absolutely terrifying. The 180-degree difference than a safe psychotherapeutic environment. People can actually have existential crises. They can actually be terrified, horrified, and certainly psychotic. So the paranoia might be a result of what might be the direct physiologic effect of a drug that she did not intend on taking and certainly didn't provide her informed consent to take. Now, again, we have to look at temporality, first onset of paranoia versus that club scene. But then again, we could always go back and reconsider, well, maybe she's knows the individual longer than having met them in that club, and perhaps this is something that predates her having been at the club. It's always a concern too. Right, we are beyond the half an hour. Any other aspects of this film you'd like to discuss? I'll take it as a no. It's a great time to tie it up, say goodbye. For those following back on Zoom, we will log on to our link in about 5 or 10 minutes to provide our case conference. Otherwise, we'll see everybody back next Friday.